Where are you? You are not visible,
Very
madam.
good evening, sir.
Good evening, all. This is Dr. Chandramohan, musculoskeletal physiotherapist from India. On behalf of Exercise Testing and Prescription Organization, we welcome all our registered participants from Saudi Arabia, Rwanda, Kuwait, Sri Lanka, Bangladesh, UAE, Nigeria, Cameroon, USA, Philippines, Malaysia, Iran, Egypt, and from many states of our nation, India. Today's topic is diaphragm, unveiling the convolutions, will be taken by Mr. Shaheem Mohammed Rasheed from Dubai. Mr. Shaheem has professional skills in teaching and practicing PNF, vestibular rehab, visceral manipulation, hydrotherapy, and manual therapy techniques. Also, he has conducted workshop on kinetic chain, stroke, neuromuscular stabilization, and many. We welcome you, sir, and also I welcome all the participants once again and my friends, Ms. Duna from West Bengal and Rupesh from Chennai. And this is our first webinar for this year. And so happy to meet you all after a long time. And over to Mr. Shaheem.
Thank you, sir. Thank you very much for such an impressive introduction. While explaining about my profile, I would like to highlight more into my DNS and proprioceptive neuromuscular facilitation, PNF, rather than the other things. That's all short courses which I have done, but I'm more into dynamic neuromuscular stabilization and proprioceptive neuromuscular facilitation. I hope I can share the screen, right?
Yes, sir. Please share.
And I expect that I am audible to all and you all can see my...
Kindly go for slideshow view, sir.
What is that?
Slideshow, sir, full screen view.
Yeah, I'm going to that. Yeah, I hope that all participants can view me and it is audible. So I'm not wasting the time. Let's go to the topic. Today's topic is diaphragm, unveiling the convolutions. So from the title of the presentation itself, you would understand I'm going to talk about diaphragm for coming 1.5 hours. So you may wonder, or you may feel that what is a big deal of talking about diaphragm in this 1.5 hours? Is that such a big thing to be discussed? Let us see if it's something new that we can learn throughout this session. Okay, further proceeding with the slides, and I would start with a question. I would like my participants to answer to this question. And the answer, if possible, try to be more genuine. The question is, diaphragm is a muscle of concern. In which specialty practice? Is it in cardiorespiratory, musculoskeletal, neuropsychiatric rehabilitation, sports rehabilitation, geriatric rehabilitation, OBG, or all of the above? I'll give you 1 minute. Please answer A, B, C, D, E, F, or G. Be precise, be genuine with your practice. What currently you are practicing and what specialty, and during which specialty do you consider diaphragm as a muscle of concern to be treated? 1
yes,
minute.
Shaheem, sir. And I request our participants, you may not find easily to write
there. They are
there.
answering in live chat box in YouTube.
Yes.
Akhil said A.
And,
okay.
Yes, please wait, madam. Those who are finding any difficulties, just subscribe to the channel so it is easy for you to write in the comment section. Please carry on, madam.
Yes, sir. A few answers have come already. Akhil says A. Kumar Manoj says G. Neelam says A. Danny, no. Christy says G. Shruti A. Reshma G. Harshita G. Shashwat Varma says G. Most of them are answering A or G, sir.
Yeah, A or G. Yeah, this is, yeah, thank you. Thank you for your feedback. The rest of the people, let them answer accordingly. So A is a wrong answer and G is a right answer. And why G is a right answer will be will be revealed by the end of the session, or by through the session. You yourself will understand why diaphragm should be considered as a muscle of concern, irrespective of the discipline, because we are not treating a patient on a specialty basis. We are treating a patient as an whole, as a physiotherapist. Okay, so why such a topic? Why diaphragm is such a big deal, and how do I come out with this topic? Is from a quote from Karl Levitt. I hope you all will be familiar with the Karl Levitt. He is a Czech physician, specialized in neurology, but later he become more into manipulative medicine, and he was renowned and famous for his teaching in manipulative medicine. He quotes that if you don't own breathing, you don't own movement. If breathing is not normal, no other movement pattern can be normal. This quote provoked my thoughts or instigate me to go and read more about a diaphragm, how diaphragm is going to affect your movement pattern. What is the big deal between the movement and the diaphragm? From my school, I didn't learn much about the diaphragm, rather than considering it as a muscle of concern, except in cardiorespiratory. In any of this musculoskeletal or neurology, nowhere we are considering diaphragm as a major muscle of concern. So with this quote, I go into detail of the literatures and books and some of the writings in DNS, or knowledge in DNS, education in DNS, dynamic neuromuscular stabilization, also give me a lot of insight into go more into the involvement of diaphragm in movement. So the highlight of the discussion today will be the regional dependence, regional interdependence, not dependence, the interdependence. This should be the base and concept of diagnostic work, and it should be also the base for the treatment of any area of the body. Our body parts are not segregated into different specialties, and they are interconnected anatomically, facially, and neurologically. So we have to treat our body as a whole. And because the nervous system are interconnected, the thing is that the patient never just has a localized symptom, but rather a system that adapts to isolated dysfunction. I request the participants to keep this point in mind, that the patient never just had a localized symptom, but rather a system that adapts to an isolated dysfunction. Whatever may be, whichever region may be, have dysfunction or pain or whatever difficulty you have, the nervous system completely will help you or reorganize to be more functional or to adapt to the situation. So there is the complete body system or reorganization for an isolated dysfunction. So we have to treat the body as an whole. So the objective of today's presentation, we will go into the base of the diaphragm, that is anatomy. We will go a little more into the neurological details, and also we go into the function of the diaphragm and the functional interrelations, how diaphragm is going to interrelate with the other structures of the body, how diaphragm is going to affect the viscerosomatic function and dysfunction, and certain therapeutic considerations, or how to look diaphragm into while treating the patient, what all the assessment methods, that's all we are going to discuss in this 1.5 hours. So in order to understand or going into the detail, is there any significance of discussing this topic for 1.5 hours? What is the prevalence? Why do you want to discuss about diaphragm? Yeah, in order to understand that, you should understand about breathing pattern disorder and its prevalence. It is estimated that 10% of normal population suffer from dysfunctional breathing pattern. This percentage jumps up to 30% among the asthma sufferers and 83% within the first people with anxiety disorder. So let us take out the second point of 30% in asthma sufferers. So as you all know that asthma sufferers there will be some breathing pattern dysfunction or breathing pattern changes. But what about the first and the last point? How much percentage it contributes? 83% of people with anxiety and 10% of normal population constitute around 93% altogether. So who doesn't have in this world anxiety, in this rat race, in this competitive world, in this world of pandemic and difficulties? So somewhere in our life, you will go through anxiety disorders or anxiety, which will affect your breathing pattern, and 10% of normal population. Might be those who are even listening to this presentation doesn't have a pathology or dysfunction or pain, but that doesn't mean that you are out of the topic. You also might be breathing with a breathing pattern disorder, or you may be change your breathing pattern somewhere in your life. So altogether, it's 93% of the population is suffering from breathing pattern disorders. Manohar Punjabi, one of the most familiar and famous name in biomechanics, who is a mechanical engineer, who stated that breathing is an uncompensatory mechanism, inevitable mechanism. So what happens is that if there is any dysfunction in diaphragm or breathing, what happens is that the motor control system will recruit an alternative and temporary factor. Why it is temporary? Because it will be just to support or continue with the breathing until the real problem is resolved. This temporary dysfunction involves the upper chest breathing or by quickening the rate of breathing. So the diaphragmatic dysfunction and uncoordination not only just affect the breathing, also it affects the stability of the spine. How diaphragm is affecting the stability of the spine, you will understand in further slides. Chest or quick breathing pattern at rest can create further adaptive and dysfunctional pattern. Then the respiratory system and movement system is subsequently further challenged. Okay, this modification or temporary adaptive mechanism, where if you continue it for a longer period of time, it will affect your movement system gradually. So now coming into the core of the topic, breathing is the most constant and necessary activity what we do. There is always a confusion between breathing and respiration. Breathing is what the mechanism in which we take in air and leave out air. It doesn't have to do anything with the transfer of oxygen and carbon dioxide between the alveoli and the blood and the tissue. We here are concentrating mainly on breathing mechanism. It should not be, the breathing mechanism should not be viewed solely just to draw oxygen into the body, but it should be linked with the well-being of entire body system. See, the second part of the point is very significant. Linked with the well-being of every body system, how every body system is affected by breathing mechanism, or how our well-being is affected by breathing mechanism will be revealed by the further sessions. Many of us, those who are even listening to this presentation, might be breathing insufficiently, taking shallow breaths using our chest muscles rather than our diaphragm. So, going into more detail, our pedagogy or our teaching methods and system have taught us body as a separate or unit. Diaphragm should not be considered, not only diaphragm, no body system should not be considered as a single segment. As I given a statement in the beginning itself, it's a body system. We are everything is linked. more and more the motor control science and facial science are evolving, it erases the our old method of understanding of single segment treatment to body system treatment. The diaphragm should not be considered as a single segment, but it is a part of a body system. What is the difference between a segment and a system? In a segment, it is just a unit, a single unit, which is functioning. But in a system, there are multiple units working in a synchronous manner to produce a result. For example, digestive system, which starts from your oral cavity to your alimentary tract to the anus. Similarly, your respiratory system also starts from your nose, which involves the nose, the trachea, the bronchus, the lungs, and alveoli, and all the systems. So all that together forms a system. If you take the nose alone, it's just a segment. Similarly, diaphragm is just a segment, but a diaphragmatic system is a combination of different muscles. Viola Furman, osteopath, American-based osteopath, spoke about treatment of 3 diaphragms, and more recently, literatures bring out 4th diaphragm. Even the current research shows that there is 5 diaphragms in the body. What are the 5 different diaphragms? Out of that, we will be here discussing about the primary 3 different diaphragms and its interconnections, how they are connected to each other. The 4th and 5th diaphragm, still now I didn't get literatures and points to be discussed. So we will be discussing about what are the 3 diaphragmatic system interconnections. Am I going fast?
No, sir. No. It's the right pace.
Yeah, it's the right pace. Okay, thank you. In order to understand more into the detail of the diaphragm, I draw your attention to our first semester or first year of your medical school, where we learned embryology. I know it's not good to draw you back to the embryology and talk all these things. I will not take more than 1 slide to discuss about this thing. It is nothing to be confusing. Its diaphragm is formed by 4 different embryological segments, that is septum transversum, that is number 1 in the green, and pleuroperitoneal membrane, that is 2 on the ash, and mesodermal body wall, mesoderm of the body wall, which is the rose color in the 3rd picture, and the mesentery of esophagus form the esophagus. So that is the red color in the center. I hope you all see that pictorial representation. So what is the significance of understanding this embryological segment is that the septum transversorium is a mesodermal mass by fusion of myotomes of 3, 4, 5. Now you see that the mesoderm means muscle mass or muscle tissue of 3, 4, and 5. Cervical segment 3, 4, and 5. So the muscle serving the neck extends to form the diaphragm. This, while maturing, the mesodermal mass forms into the central tendinous part of the muscle, and that is the central pleura or upper and peritoneum on the lower side of the diaphragm. The second is pleuroperitoneal membrane, which emerge from the lateral side of the body. From the body wall, grow medially and fuse with the septum transversorium. Forms the peripheral part of the diaphragm, and it drives the sensory supply because it is coming from the body wall. It drives the nerve supply from the body wall itself. Then the 3rd one is mesoderm of the body wall, and the 4th one is the mesentery of esophagus. So embryologically, diaphragm is connected to the cervical segment, which is very important. You have to keep in mind because we will be discussing later. We will understand why there is an embryological relation between the cervical segment and the diaphragm. And there is a pleuroperitoneal. Pleura means which is the thoracic fascia, and the peritoneum is the abdominal fascia. and there is body wall connectivity, and also our digestive system also, or your food tract is also having contribution to the diaphragm. Now itself you would understand that where all the diaphragm has been spread their roots from the embryology itself. Now let us start with so when it matures, when the diaphragm fuse, all these 4 segment fuses, it becomes a complex tissue comprising 2 half dome shaped musculofibrous tissues of 2 to 4 millimeter thickness, which is the main muscle of respiration or inspiration, normal inspiration. It is a fibromuscular sheet which separates the thoracic cavity and abdomen. This all is with what we have already drawn. Convex upper surface forms the floor of the thoracic cavity, concave undersurface forms the roof of the abdominal cavity. Functionally, it is controlled, neurologically controlled by autonomic nervous system and central nervous system. Restful breathing is referred to as belly or abdominal breathing, irrespective of the gender. Now let us go into the first objective of our presentation is anatomical description. And anatomically, diaphragm is divided into 2 portions, the central tendinous portion and the peripheral muscular portion. And the peripheral muscular portion have a sternal origin, the costal origin, and lumbar origin. Let us go one by one in detail. It won't take much time and make you more boring. It's all base anatomy, which the sternal attachment arises 2 fleshy slits from the posterior surface of sigmoid process. The medially, there is something called, there is an opening called the Larry fissure, which is covered by the fascia, through which pericardial connective tissue contacts with the peritoneal connective tissue. So there is a facial connection exists anteriorly between the thorax and the abdomen through facially, and that means I just meant to say there is in the interconnectivity, there is no complete separation between thorax and the abdomen. There is an interconnectivity facial crossing the diaphragm, and laterally the foramen morgagni covered by the pleura and pericardium, and via this opening the retrocostocyphoid hernia can occur. So this is not a concern, I think completely not a concern with the physiotherapy, but still as discussing, I have to discuss about it also, just to mention it. And the second attachment is the costal attachment. You all know that the costal attachment, embryologically, it derives from the body wall also. So the costal attachment is a part of the body wall embryologically, which arises in the inner surface of the cartilage of the lower 6 ribs. This interdigitates with the transverse abdominis. It shares the fibers with the transverse abdominis muscle in the abdomen. Then coming to the lumbar attachment, this have a more physiotherapeutical significance. The earlier one also have more physiotherapeutical significance. The medial lumbocostal arch, which is a tendinous arch which bridge the fascia, the tendinous arch with the fascia covering the psoas major muscle. Medially, it is attached to the side of the body of the L1 vertebra, and laterally it is attached to the transverse process of the L1 vertebra, and this arcuate ligament bridge the psoas major muscle. So there is an connectivity or facial or intersection relationship between the psoas major muscle and the diaphragm. So the next is the lateral lumbocostal arch, which is the tendinous arch formed by the fascia covering the quadratus lumborum muscle. Medially, it is attached to the transverse process of L1 vertebra, and laterally it is attached to the 12th rib. And this bridge the quadratus lumborum muscle. There is a space, a facial free area between the medial and lateral, which is called Bodlak's triangle or lumbocostal triangle, which is also a possible area of hernia, posterior hernia. There is an anterior possibility of hernia and posterior possibility of hernia, but that is not our concern. Our concern is it covers the quadratus lumborum muscle, or it is closely attached bifacially, and there is an intersection of the muscle fibers of the diaphragm and the quadratus lumborum. And coming to the final attachment is the Lampara, the other part of the lumbar attachment is the right and the left crust of the diaphragm, which arises on the anterior surface of the body of upper 3 lumbar vertebra and intervening intervertebral disc, and a thicker and longer flat tendon on the right side and thinner flat tendon on the left side. There is a slight difference in the attachment. The right side is to L2 to L4 and left side is to L1 and L2. The margin of 2 crests forms the tendinous arc across the front of aorta. Okay, when you go the median and lateral superiorly, it gives a space for the aorta, which is the medial arcuate ligament. So you see that the crust of the diaphragm is attached to the lumbar vertebra. So why do we want to discuss about the anatomical attachment? One more thing which is very important is the medial and lateral pillar makes contact with the retropericardial and perinephric tract and their related fascia. So anteriorly also the thoracic contents and the abdominal contents are connected facially. Posteriorly also the thoracic and the abdominal contents are connected facially and facially. So what is the significance of this thing is that the visceral fat is a source of proprioceptive information. As we have evolving with the facial science, you know that more proprioceptors are present in the fascia rather than the tendons and the muscles. So any irrelation, any pathology, any dysfunction in any of these organs, whether it is lungs or heart, or whether it is a liver or a duodenum, or it is spleen or kidney, any dysfunction can affect the smooth and proper movement and function of that. Hello? Is it?
Yes, sir. Yes, please.
Yes, sir.
It's all okay, right?
Yeah.
Yeah.
Yes, okay, sir.
So the last part, whenever there is an organ, we should also discuss about the insertion part, which is formed by 3 leaflets with a trilobar shaped central tendon. The middle leaflet is a triangular shape with apex facing towards the xiphoid process, and the central portion will well marked diagonal. There is some decussation of the central facial fibers wherever there is opening for the esophagus, the vena cavas, etc. The right and left leaflets are tongue shaped, whereas right is more broader and left is narrow. There is a significance in right is broader and left is narrow is because right have to resist the more heavy organ called the liver, whereas left doesn't have to do that much of resistance. That is why the decussations or the fiber arrangement in the central tendon is more broader on the right side. The upper surface of this insertion fuse with the pericardium. So what are the anatomical, what is the interrelationship, or is that anatomically or structurally, organically, diaphragm is related to the rib cage, diaphragm is related to the lumbar spine, lumbar diaphragm is also related to the psoas major muscle, and also diaphragm is related to the quadratus lumborum muscle. So any of the dysfunction, vice versa, they are interrelated. So either diaphragm dysfunction can lead to the dysfunction of any of these structures, or any of the structural dysfunction can vice versa affect the function of the diaphragm. So anatomically, they are interconnected and interrelated. the quadratus lumborum strain, sprain, or costochondritis, or inspiratory position of the rib, or expiratory position of the rib. I'm talking about not about the lung. Apart from lung dysfunction or the other interrelations, even the lumbar spine disorders can even affect the smooth and the synchronous function of the diaphragm. So that finishes the first objective of my presentation, the anatomical aspects. Now let us go to the fascia and ligamentous aspects of the diaphragm. What all happening with the fascia and ligament, how all diaphragm is interconnected. Okay, the superior diaphragmatic fascia merge with the pulmonary pleura. That is, we all know this. This is proven, and it is. I don't have to much go into the detail, which is the base of our cardiorespiratory education. And coming to the next is the inferior diaphragmatic fascia merge with the peritoneum. The peritoneum, that means the facial covering of the all intestine, is also attached to the diaphragm through inferior diaphragmatic fascia. And the third facial attachment is the lung. Again, the lung have a direct, apart from the pleural connectivity, the inferior pulmonary ligament connect the lung to the superior surface of the diaphragm. The phreno-pericardial ligament connect the heart to the superior surface of the diaphragm. So heart is also ligamentously connected to the diaphragm. And yeah, this is, we discussed in the embryology, the esophagus. Phrenico-esophageal ligament connect the esophagus to the diaphragm with a loose connective tissue. There is a connectivity between the esophagus and diaphragm. So what is the significance of all this? We will be discussing in further sessions. We will understand much more in detail as going through. There is a facial connectivity between the liver and the diaphragm hepatic ligament, that is the falciform ligament, right and left triangular ligaments form falciform ligament, and formed by subdiaphragmatic peritoneal thickening. So diaphragmatic peritoneal thickening forms the right and left triangular ligament and forms the, so there is a hepatic connection with the diaphragm. And furthermore, if you go into the more details, the ascending colon have a direct phrenicocholic ligament or Hensing's ligament connect to the diaphragm to the ankle of the right ascending colon. So there is a connection between the ascending colon and this is visceral relationship. There is another called Treats ligament which connects the duodenum. Connect to the left crest of the diaphragm to the duodenojejunal junction. This ligament connects to the diaphragm. So now this is a video without any audio. Just look at this movement and look at the, do you find any similarity between, is there any resemblance with any other movement of the body? The movement which is taking place inside the brain, there is two things. There is pulsation and there is movement. Once more, I will play the video. Okay, there are, you can see in the video, there is pulsation and also there is up and down movement in the brain. So this is nothing but the movement of the diaphragm is not limited to the surrounding structures, the superior and inferior nearby structures, but it also affects the well-being of the very distant structure called the brain through the facial connectivity. How this movement is affecting the brain or how this movement is reaching the brain is through the facial tensegrity, where when the diaphragm is moving up and down, it is not solely moving up and down, it's moving with the organs up and down. All the lungs, the heart, the liver, the intestine, the spleen, the kidney, everything is moving along with it. So when the structures are moving, they are moving with the nerve connectivity. When the nerves are connected, the nerve fascia like epi, endo, and perineurium is moving. When the epi, peri, and the endoneurium is moving, the dura, arachnoid, pia mater is moving, and the brain is moving. And this helps in the nutrition of the brain, thereby it enhances your thinking process and intellectual capacity and well-being of the nutrition of the brain, fluid flow in the brain, waste drainage in the brain, and etc. So facial ligamentous interrelationship doesn't limit just to the nearby structures. It is connected to the diaphragm. It is connected to the peritoneum. It is connected to the ascending colon. It is connected to the liver. It is also connected to the heart. It is connected to the esophagus and many more connections. So again, the nervous system is interconnected. We cannot separate the nervous system. So any pathology of these surrounding organs can affect the diaphragm, and vice versa. Diaphragm dysfunction can affect these organs too. So I just want to draw the attention to the interconnectivity and the reciprocal relationship between the body organs. Now you can, I think you start getting the idea that diaphragm is slowly expanding to all regions of our body, not just limited to the cardiorespiratory system or just drawing in oxygen. It's slowly spreading its roots to all areas of the body, which is very significant to understand. Now coming to the functional anatomy, which is the third part of my objective. So let us go to that. Now, functional interrelationship. You look at this structural similarity. Have you ever noticed about this structural similarity? What is the relationship? What is the similarity between these two structures? And one is diaphragm and one is pelvic floor. You see that both are completely covered by bony structures, and both have muscle flaps covering the central region, and there are holes for the transfer of certain structures. Okay, so they are structurally similar. Diaphragm have another correlation with the pelvic diaphragm during the normal respiration. While studying about respiration, we only talk about the movement of the diaphragm. But when you look more functionally, there is similar movement occurring with the pelvic floor while you are respiring. If you are properly using your diaphragm, then there is the neural synchronization will cause the pelvic floor also to produce a similar movement. For example, this can be noticed with some reflexive movements like coughing, huffing, etc., or even defecating, etc. You can see some interrelation if you just feel it. When you cough or huff, sometimes you can, along with the forceful expiratory push of the diaphragm, you can see there will be a pelvic floor contraction. There will be anal region contraction. You can feel it. For instance, if during inspiration, the main inspiratory muscle descent, there will be a corresponding lowering of the pelvic floor. You will understand this more detail with this representation. This process has been confirmed during real-time magnetic MRI studies in living objects to study, which is done for the study of intra-abdominal pressure. Various studies established that before inhalation, electrical activity can be observed in the pelvic floor muscles of the abdomen, that is the transverse abdominis and internal oblique. So here is a video without audio. Again, you can see what is happening. I want all you to see the movement in the pelvic region. You see the movement. This is the diaphragm. Okay, this is the liver. What you see here is the diaphragm, this black region. Here is the liver and this is the stomach, and all you, when you see, go down to the movement, you see the beautiful movement happening. Once more I will play. You can see this simultaneous movement is happening on the pelvic floor, and this happens only if you use the diaphragm. And what is the role of this thing? It will help in the visceral health, visceral well-being, the movement of the visceral organs, and it will help in digestion. It will help in metabolism. It will help in excretion. It will help in smooth functioning of your alimentary tract, etc. Okay. Okay, so that finishes my third objective, and coming to the fourth objective is the nerve supply. When we are talking about nerve supply, there are certain basic things. It is nothing to be discussed in detail. The phrenic nerve, C345. Now, there is again, so before discussing about the nerve supply, now I just want to say that slowly diaphragm is becoming a diaphragmatic system. Have you noticed during the session? Have you noticed that diaphragm is slowly becoming a diaphragmatic system? That means it have a functional connectivity with the pelvic floor. So we got now the second diaphragm called the pelvic diaphragm, which is connected to the thoracic diaphragm in function. Okay. Now let us go to the nerve supply. Then we will connect it to the other diaphragm. Okay. So then we will elaborate the system. Okay. So nerve supply, it is the phrenic nerve C3, 4, and 5. You see that phrenic nerve, the embryology, the septum transversorium, the mesodermal mass arising from the cervical segment C3, 4. So the nerve supply also comes from there because it emerges from there. So the driving force is coming from where? From the cervical segment. So the diaphragm is through the neural connection, it reaches the cervical structure. Okay. The lower thoracic, sixth thoracic nerve supplies the peripheral part of the diaphragm, and there is something called the vagus nerve. The sensory and motor component of the deep crural region fibers are innervated by the vagus nerve. When we are discussing about the nerve connection, mostly we will say about the phrenic nerve. Okay, mostly we discuss about only phrenic nerve. What is the vagus nerve? You know, it's a cranial nerve. It's a cranial nerve. We don't have to discuss with in connection with the diaphragm, or we may neglect the involvement of vagus nerve in connection with the diaphragm. But it has a very why there is two different connections. Why the evolution make it like that? There is a two. You will understand it later. There is a functional significance with the vagus nerve supplying the central region of the diaphragm. So, in order to understand more into the neural intricacies of a diaphragm, let's go back little to the neuroanatomy. I don't want to bother you, or make you boredom. Let's go a little back to the neural anatomy or neural course of phrenic nerve. As you all know, it comes from the nerve roots from C3, 4, and 5. From where it gets the presynaptic nerve supply is from the phrenic neuron. Neurons are housed in the lamina 9 of the ventral horns of cervical spinal cord, and from where it gets the connection is from the medulla. It gets the connection from the medullary respiratory center. The cervical spinal cord receives the presynaptic impulses from pre-Botzinger complex or parafacial retrotrapezoid nucleus. Pre-Botzinger complex is in the medulla, which have two. And this pre-Botzinger complex receives nerve supply from the Fontaine centers like pneumatic respiratory center and apneutic respiratory center. And there are two medullary centers also, dorsal respiratory DRG and ventral respiratory group of centers. why do we want to understand all these things? We don't want to discuss all these things. You may think about, no, there is a big significance. Then only diaphragm will become a diaphragmatic system than a segregated diaphragm, isolated segment. So the importance is that let's go more into this brainstem interconnectivity of the phrenic nerve a little bit. Please bear with me. The pontine respiratory center and the medullary respiratory center are connected by interneurons. Okay, this see this interneuron. Yeah, this interneuron. Okay, this interneurons pass by something called retroambiguous nucleus housed in the medulla. This is the retroambiguous nucleus. This interneurons from the pons pass through this retroambiguous nucleus, and this retroambiguous nucleus controls the floor of the mouth, the pharyngeal and laryngeal muscles, the external and internal intercostals, and the abdominal muscles. So now slowly diaphragm become interconnected to the third diaphragm called the buccal diaphragm. That means the floor of the mouth. So why there is a diaphragm neuronal connection with or secondary or tertiary or distant connection with the floor of the mouth? If this connection is not there, suppose if there is no disconnection, this connection is not there, or we cut it off, what happens is that when the diaphragm draws the air in, the tracheobronchial tree, not bronchial tree, the tracheal area, the upper part of the respiratory system will go for collapse. It will obstruct the free flow of air. In order to give an unobstructed free flow of air, the floor of the mouth, the pharyngeal and laryngeal muscles should counteract the negative pressure inside the upper respiratory system to keep the upper respiratory tract patterned and open for the free flow of air. For this purpose, there is an interneuronal connection between the phrenic nerve and the retroambiguous nucleus. So now functionally, the thoracic diaphragm gets connected with the pelvic floor, and neurally the thoracic diaphragm gets connected with the buccal diaphragm. So now we got a diaphragmatic system or respiratory system, respiratory diaphragmatic system with three different diaphragms interconnected called buccal diaphragm, the thoracic diaphragm, and the pelvic diaphragm. So now let us function together. How these three functions together. Also, this phrenic nerve receives afferent from the pericardium, liver, vena cava, peritoneum. Okay, so there is also already facial interconnectivity with the visceral organs to the diaphragm, and also there is neural connectivity between sensory. That means proprioceptive connectivity between the nerve supply between the heart, liver, and the vena cava, etc. So the diaphragm is connected to everything in the body, I can say. Now, more into the diaphragm, more into the neural functionality. We just discussed about the nerve root, C3, 4, and 5, the phrenic nerve. No, it won't limit like that. It doesn't limit in that sense. Okay, this 3, 4, and 5 or 6, the prefix is 6. Actually, 6 is not there in some cases. There will be 6, and C2 sometimes the prefix and the postfix. The prefix C2 sometimes it will be there along with the phrenic nerve, or sometimes it won't be there. Commonly, it is C. The major nerve roots for the phrenic nerve is C3, 4, and 5. You can see the cervical plexus and the brachial plexus. Cervical plexus is C1, 2, 3. So part of the phrenic nerve is there in the cervical plexus. Part of the phrenic nerve is there in the brachial plexus too. So what happens if there is a phrenic nerve involvement? Phrenic disorder, or if there is a breathing pattern disorder, it will affect the neural transfer or neural function of the phrenic nerve. If the neural function of the phrenic nerve is affected, it can also start giving irritation to preauricular nerve C2, C3, prevertebral muscles and the sternocleidomastoid C2, C3, levator scapulae trapezius scalenus muscle C3, C4, dorsal nerve of the scapula C4, 5, axillary nerve C5, C6, supraclavicular nerve C3, 4, musculocutaneous nerve C5, 7, and subclavius nerve C5, 6, etc., etc. And so diaphragm disorder doesn't limit with the breathing, but also it can give you troublesome dysfunction in the cervical region, the brachial region, the shoulder joint, the shoulder problems, shoulder muscles, etc., etc. Okay. Diaphragm dysfunction doesn't limit. The patient might be coming to you with a shoulder pathology or cervicogenic headache or a recurrent neck nodes or wryness, recurrent wryness. The sole reason might be from the diaphragm, but you might be treating the cervical, or sometimes there will be dysfunction in the shoulder, but the sole reason for the shoulder pathology can be from the diaphragm. Let us go a little more into the detail how this neural connectivity will affect the muscles of the cervical and what is the effect of that with any aberrant or excessive neural drive. As I said, breathing pattern disorder or diaphragm dysfunction. When the diaphragm is dysfunctional, the sensory supply will send impulse to the nerve root. This nerve root is shared by the cervical and brachial plexus. And what happened is that there will be slight neural disorder or neural transmittive disorder happening in this plexus or nerve root shared by the corresponding plexus. And it will cause brachialgia, thoracic outlet syndrome, motor control dysfunction, neck, arm, and shoulder. What is motor control dysfunction? It's mainly the stability. The tonic muscles are mostly affected. What are the tonic muscles? These muscles are the muscles, feedback muscles. So just before any movement you initiate in the shoulder or in the cervical region, the primary muscles to activate is the tonic muscles to create stability in the joint. These muscles are optimizing the motor control. That means the stability and control mobility of every joint. And also it maintains the optimum instantaneous axis of rotation. These low threshold muscles are primarily affected with any irritation in the phrenic nerve, which this phrenic nerve roots are shared by this cervical and brachial plexus. And it will slowly give some problems, which is unnoticeable or clinically insignificant for time being. But what happens, clinical significance is that this disruption in the tonic muscles affecting the what is that? I forget the abbreviation. What is that? Instantaneous axis of rotation. Yeah, the muscles which are supplying the instantaneous axis of rotation. And this happens for months and years. It will be subclinical for a time period. Then slowly gradually it will affect the subacromial impingement. And usually we treat it as subacromial impingement. But this might be a long-term result of a breathing pattern disorder. So we have to keep in mind while treating the cervical region, the thoracic outlet syndromes and shoulder pathologies, whether the patient is having a good breathing pattern or whether he is using the complete diaphragm for his breathing. So more and more the diaphragm fibers are not used, the more and more they will be switching to the cervical muscles, the secondary or the adaptive mechanism to switch on. Okay. Yeah, a little more into the course of the phrenic nerve. While the phrenic nerve descending down to supply the diaphragm, it also passes through the fascia of anterior scalene muscle. Injury to anterior scalene, such as whiplash, direct trauma, forward head posture, upper cross syndrome, can even detrimentally affect the. So this is the vice versa function. That means Either the diaphragm pathology can affect the neural aberrant flow of the nerve supplying the neck and affect the neck function, or the neck disorder, or you get an injury, a whiplash injury. A whiplash injury, yeah, nothing to be worried. Just treat the sternocleidomastoid, the scalene muscles, and just use some proprioceptive training to the muscles. But if this whiplash injury cause any neuropraxia or anything to the phrenic nerve, the breathing pattern have been changed, but we didn't notice it. We treated the nerve and the neck function become normal, and the patient is fine, so we left them, but we didn't look at how the breathing pattern is. So we have to look into whether patient comes with a definite cervical pathology. We have to even look into that. So yeah, functionally diaphragm can be divided into 3 distinct regions. The crural responsible gastroesophageal reflex, which is this condition, gastroesophageal reflex, until now we consider this is not a physiotherapy concern, but let's see whether physiotherapy can do something on it. There is crural region. You see this picture, crural region, the central tendon and the costal region responsible for correct breathing. This separation has an anatomical function because during deglutition, that means when the food bolus passes through your digestive tract, and while vomiting, diaphragm function in a separate way. Okay, this diaphragm area must work at different timing with a different innervation for esophageal distension to happen while breathing. You understand now why there is a 2 nerve connection in the diaphragm? Because there should be uninterrupted food flow. Okay, let us go down. Let us see what is the vagophrenic interaction. The vagus nerve runs through the crural region of the diaphragm, innervating that region, which serves both sensory and motor fibers to the deeper portion of the crural region where the esophagus pass by. Nearby region is supplied by motor and sensory is supplied by the vagus nerve. Phrenic nerve along its pathway anastomosis with the vagus nerve. There is an anastomosis also between the phrenic nerve and vagus nerve. So what happens? This interaction explains how swallowing is uninterrupted with synchronized breathing. Let us go and see how the swallowing is happening. We start chewing and the food bolus passes by. If there is no vagus nerve, or if the vagus function is disrupted, what happens is that the diaphragm will be contracting and the food bolus will be obstructed in this region, the vagus nerve. So vagus acts as an inhibitor of that central region. So the phrenic nerve will passes through its anastomosis, process the signal that the vagus nerve will passes the signal that to the phrenic nerve, stating that there is this thing happening. So what happens? Vagus nerve inhibit that central region, while phrenic nerve will do its function on the other parts of the diaphragm. So maintaining the breathing, the swallowing food bolus passes the gastroesophageal junction by the relaxation of the crural diaphragm due to the inhibitory effect of vagus nerve on the medullary and phrenic motor neurons. So what is the significance of describing this vagoesophageal? Your patient might be suffering with GERD, gastroesophageal reflex disorder, since long time, but which is not our concern. But if you look into the diaphragm function, the diaphragm itself is not functioning. That means there is the phrenic nerve is not functioning. If the phrenic nerve is not functioning, there is no interflow of the messages, the sensory messages, whether the food is coming, whether no food is coming. So what happens is that the vagal inhibition will be continuing for a long time, and that esophagogastric opening will be kept open for a long time. So what happens is that when the esophagogastric opening is open, what happens? The food bolus will be freely flowing with some interactions, with some irritation. You might have seen in old age patients who have repeatedly having what is that? Reflex esophagitis, or a reflex flow of reverse flow of the gastric contents, producing heartburns and sometimes even aspiration and coughing and severe disorders. So this might be because of the diaphragm dysfunction, and through which the phrenic interrelation with the vagus, which should relax after a while. Otherwise, the continuous inhibition of the vagus nerve will keep the distal opening of the esophagogastric opening. So, some directly or indirectly, while by treating and reactivating the diaphragm, you can even treat the gastroesophageal reflex disorder, helping the patient who is suffering from long time GERD can be treated with a diaphragm treatment. Okay, now, yeah, okay, now obviously there are a lot of structures crossing through the diaphragm. There are aorta, there are esophagus, there are sena cavas, there are, along with that, there are sympathetic and sympathetic nervous system is also passing through this diaphragm. So if there is a diaphragmatic spasm, if there is no diaphragm movement, or if there is a particular part of the diaphragm is not moving, anything can even affect the sympathetic nervous system. When the sympathetic nervous system is affected, it will go for either up regulation or down regulation. So through the sympathetic system, the whole well-being of the human body is affected. It affects many functions, which I am not going into details. If you want to go in details, another 1.5 sessions just about the sympathetic and parasympathetic system and the social engagement system I have to discuss about. So I'm not going, I'm just cutting now the sympathetic system can be affected with the spasm or dysfunction of the breathing and causing the well-being of the whole body of us. All that passes through the central region of the diaphragm. This suggests that during events of diaphragm dysfunction like spasm or atrophy, the sympathetic system will be negatively affected in both upward and downward direction. Thus, the muscles, the vertebral facets, the related tissues close to the metamere innervated by those three plexus will suffer from pain. Okay. This is little exaggeration, but still, fact is fact. We cannot restrict little exaggeration more into to increase the severity of the diaphragm dysfunction into the central nervous system, or to the brainstem level, to escalate the diaphragm dysfunction to the brainstem level based on the neurophysiological principles. As you all know that orthotomic, antitomic, and local conduction. What happens when there is a phrenic disorder, depending on the nature of the muscle contraction? What happens is that nerve is not just conducting the nerve impulses. It also conduct the immune substance and chemobiological substances and neurotropins, nerve growth factors, etc. So a disorder of the phrenic nerve, if the diaphragm is not functioning, or if the diaphragm is struggling because of any musculoskeletal or somatic issue or visceral issue, diaphragm is struggling. So what happens? The sensory is the play of the phrenic nerve will pick up or the sense and send the message to the brain. So along with the messages, it also send the chemobiological and immune substance to the brain. What happens? This immune substance, when it reaches the brainstem, that is the medullary motor neurons. The medulla and the pons are the region where there are a lot of motor neurons are originating and descending and supplying. So what happens? These come up chemobiological and metabolic information to the medullary and interneuron adjacent to the set of phrenic nerve neuron affect other sensitive motor neurons at the same level. It also affect the other motor neuron or other cranial nerves, whether ipsilaterally or contralaterally. So that is about the neural intricacy. Now, let us come to the diaphragm, the secondary function of the diaphragm. While discussing about the diaphragm anatomy, it is 75% respiratory muscle. So what is the 25% diaphragm? So diaphragm is also helping in some other things. And when you look at the anatomical attachment of the diaphragm, yeah, diaphragm is also attached to the lumbar vertebrae directly, not to the transverse process through the arcuate ligaments, directly to the body of the lumbar vertebra. So, is there any relationship between diaphragm and lumbar stability or lumbar this thing? So, lumbar diaphragm is also known as a postural diaphragm. Okay, diaphragm begin to fulfill its role as postural is when the chest breathing is coordinated with abdominal breathing at the 6th month of age. When you notice the child, until for the first 3 months, they are flat on the floor or wherever they lie down with the legs straight, and gradually, as the developmental process progress and neural maturation occurs, what happens is that neuromusculoskeletal maturation slowly start connecting the separate systems, or our spinal reflexes get integrated to the brainstem reflexes to the cerebral reflexes. What happens is that, or cerebral motor control, slowly each region gets connected. Now what happens by the 6th month, baby start lifting both legs and connect the pelvis to the thorax slowly, neurologically and function. When the legs rotate or the start lifting from the ground and face the pelvic floor starts facing the diaphragm, they start slowly getting connected posteriorly. Diaphragm play an imperative role in spinal stability and all resultant movement, especially during complex tasks and comprises athletic performance. Postural stability function of diaphragm is by formation of abdominal canister, which accomplished by working in conjunction with other muscles such as transverse abdominis, pelvic floor, and deep intrinsic muscles of the spine, that is the multifidus, in order to create sufficient stiffness in the spine. Abdominal canister minimize other intrinsic and extrinsic stressors to the spine during motion. I will explain it much more in detail about the postural function of the diaphragm. In order to understand the postural function of the diaphragm, we should know what is abdominal canister. As I mentioned just before the slide, it is the synchronous function of a group of muscles which include the diaphragm, the pelvic floor, the transverse abdominis, and the multifidus muscles working together. Whenever you start, you intend to start any movement against gravity, the feed forward mechanism will activate the postural reflex, through which all these muscles simultaneously, synchronously work together to stabilize the spine. So why do we need such a complex system in the lumbar region? Similarly, there is a cervical region which is not supplied in order for stability. The cervical segment is not given such a complex system, whereas in the lumbar region they are given a complex system. Why it is so is because of the length of the cervical and the lumbar region, and the body weight or transfer also. The cervical segment have to take only the weight of the head, and because of that, the neck muscles are very close to the spine. They act as a stabilizers. When coming to the lumbar region, they are lengthy, they are long, and also the body weight distribution is higher. Depends on how much body weight you are. And when you look at this, the difference between neck stabilizer and this stabilizer is the neck stabilizer are close to the spine. Okay. Whereas when you see this stabilizer, there is the linear distance between the muscle, the transverse abdominis, this thing, and it's so far from the spine. Then how do it help in stabilization? Can be explained through a pneumatic mechanism called intra-abdominal pressure. When all these four muscles or intrinsic myokinetic system works in conjunction, what happens is that a pneumatic compressive system start activating inside the abdomen to stabilize the lumbar region. So if you, metaphorically, when you explain it with a balloon, when there is an anterior contraction from the transverse abdominis, there is a possibility of frontal stability, and there is a longitudinal distraction movement in the balloon, because posteriorly it is stabilized by the lumbar, the balloon is stabilized by the lumbar spine, anteriorly the transverse abdominis, and up and down there is a movement of the diaphragm and pelvic together. So what happens is that longitudinally there is a destructive force, and frontosagittally there is a compressive force affecting the lumbar region, helping the lumbar region to keep the lumbar vertebrae in the concentric on the center of what is it called? I forget that. Joint centrated position. What is joint centrated position? You will understand. Or what is the significance of what is the muscle activation pattern? Physiological concentric pistoning movement of the diaphragm, eccentric control of the abdominal quadratus lumborum serratus posterior, inferior, and the pelvic floor, caudal movement of the diaphragm, etc. This is not much significant. Yeah, this is intrinsic myokinetic system, trunk bracing by actually, when you think about the trunk bracing, most of them will be thinking about tucking the belly button. It is not like that. Activation of transverse abdominis actually gives an outward pressure, not an inward pull of the abdomen. It's not like tucking the abdomen in. It is a push to tonicize the transverse abdominis. Trunk bracing is the intrinsic myokinetic system maintain all spinal segments in a biological neutral position during the course of movement, which is described as a joint centration. So what happens is this intrinsic myokinetic system is, there is tit for tat. If there is no intrinsic myokinetic system is activated, this is the first picture is the normal. That means the pelvic floor and the diaphragm is facing together, and the abdominal wall is contracting. The pressure is giving a pneumatic compressive system in the anterior aspect of the spine, and the body is in a good neutral ideal posture. What happens in this second picture? The pelvis lose its posture. What happens is that there is no intrinsic myokinetic system. There is loss of stability in the spine, and the patient posture also changes. This is diaphragm inclined. This is pelvic inclined. This is both inclined. In either the case, the intrinsic myokinetic system is lost, and the patient posture is lost, and the movement is lost. So that when the diaphragm reaches in this position, in either the case, what happens? The breathing pattern also changes. We will have to lose two things in this situation. That is, breathing also will change, and also the posture will change. This lead to what is joint centrated position? It is a normal anatomical position of the joint where there is no excessive compressive force anteriorly or posteriorly. The annular ligaments are well loaded. There is no excessive force. There is no chance of rupture. There is no stress or strain in any of the anterior contractile structures. The muscles, the ligaments are in perfect alignment. There is no shortening. There is no laxity. There is no over contracture, etc. So that is joint centrated position. Okay, what is decentration? What happens in decentration? When there is one part of, suppose if one part of the diaphragm is not functioning, suppose in this case it is the left diaphragm is not functioning, so there is left dysfunction of the intrinsic myokinetic system. There is a decentration in the weight transfer. There is excessive compression in one side of the annular ligament, and repeated for a long time contraction or long time situation can affect the disc protrusion. Okay. So ultimately, what I want to say is diaphragm is not a single muscle. It is a system, and also it has a multiple function. It is a postural muscle. It is a spinal decompressor muscle. It is a thoracoabdominal pump. It is a spinal stabilizer. It is a deglutition muscle. It is vocalization muscle. It is emotional regulation. This area we didn't discuss in details. As I told, this area can be covered with when you explain about sympathetic and parasympathetic and relationship between that things. It's out of scope of this presentation, which is there is a it helps in fluid dynamics. It helps in venous return from the lower part of your body. The visceral mobility. It helps in visceral health. It helps in abdominal straining, expulsive functions, sneezing, coughing, laughing, huffing, crying, vomiting, defecation, paturation, and deep inspiration, etc., etc. So these are the function of a diaphragm. I think I have 15 more minutes. Is it right? Am I right?
Sir, if it is over, then we can go for the discussion session, or if you want to share any more information regarding this
Sir,
topic.
you have time, sir. Continue, please.
Yeah, I have 15 minutes. So now let us, the one more objective is there. I have to meet that, sorry. Okay, so now treatment, what are the things to be considered while taking diaphragm as a muscle of concern or any condition? You have to know the mechanism of breathing. The diaphragm flatten causing compression of the internal organs. Diaphragm flatten extend the superior and inferior dimension of the thoracic cavity. External and internal muscles elevate the ribs, extend the sternum, extend the anterior and posterior dimension of thoracic cavity. The lower rib cage moves the proportionality of and symmetry in lateral ventral. This is very important part. The expansion of the lower rib cage will cause symmetrical lateral, ventral, and dorsal direction. Expansion of that thoracic abdominal cavity, thoracoabdominal cavity will be expanding in all these aspects, because when you look at the scales, they explain about the dysfunction of diaphragm into 5 different scales. That I will come to that later. Diaphragm move caudally during the pelvic towards the pelvic floor with symmetry. The sternum moves ventrally while the intercostal space expands, and these all are normal things which you all know and affect you functional diaphragm. Okay, fine. Coming to the therapeutic. Okay, this is okay. So when there are normal breathing and forced breathing. The earlier what we explained is normal breathing. What is forced breathing? We use forced breathing in 2 different scenarios. One is in pathological conditions. That means diaphragm dysfunction. In any way, where maybe it is visceral, neurological, or somatic, or emotional, or any reason, or pathological. And another common normal day-to-day this thing is doing any exertion. That means exercising. Also, you use this accessory muscles of respiration. There is no nothing wrong in using this respiratory muscles for a short period of time. But if you use it for a long period of time, it is it has to be taken into consideration. Expiration is normally a passive process. Diaphragm doesn't have to involve in that, because lung complaints and elasticity will recoil, and fascia also recoil, and expiration happens. But when you come into forced expiration in pathological condition, obstructive disorders, you have to use force the diaphragm. You have to use activate the diaphragm to force the air out. The incapability of the diaphragm again will cause more and more air to fill in. That is, you see in COPD and all other respiratory cases, more and more air, and you become like what is called pink puffer. Yeah, I think I'm not into more into cardiorespiratory. I'm sorry for that. Pink puffer, you become more and more blotter and blotter because the air is getting trapped inside the lungs because of the inefficiency of the diaphragm and the obstruction of the upper part of your respiratory tract. So this is a video again. Just listen to that, what is happening, the real-time MRI. I'll not be describing anything. Just look into the video. It's 1 minute or 2 minutes video. You look what is happening with the normal breathing. The rib cage is expanding. The diaphragm is going down along with the organs. You see, this is the liver. Where is the cursor? Yeah, this is the liver, the stomach, the intestine, the heart. There is stretching of the diaphragm while going inspiration, and the stretching of the intestine is undergoing for expiration. So there is a facial mobility of the thoracic and the abdominal contents. There is free flow of impulses, blood flow, etc. It will help the ideal and normal function of the visceral organs. It will help in digestion. It will help in metabolism, and so on. Okay, so this is the mechanism by which stretches the heart. You see, it stretches the heart. Do we ever try to stretch the heart? We never try to stretch the heart. But if you just do proper breathing, these yogis give more emphasis on pranayamas. To be frankly speaking, I don't know the intellectual capacity. They give more importance. They give up one particular area just for breathing and different type of breathing. And throughout the yoga session, they integrate breathing into any posture or any asana. So they have that insight of saying that the diaphragm have a major role in the well-being of a human being, not just building up some muscles around the body. It also, the internal harmony is required for the well-being. So going into the, okay. So I think my objective is met. I'll just go through some things about how this happens, how breathing pattern disorders switch in, or how it starts. Whenever there is a pain, actually what happens is that we all are born with the statal reflexes. Okay, statal reflex, suddenly what happens is when you give a loud noise or a jolt or a jerk, what happens is suddenly there is a cessation or hold of the breath along with the contraction of the entire muscles. As age progresses, as you all know, the neural maturation, the statal reflex gets integrated. It's not inhibited, it's integrated. That means it still persists. But what happens when there is integration? Every neonatal reflex is getting integrated. That means still it persists with a higher intensity of stimulus. It's not just with a small sound you will get startled, but you need a loud sound or a high intensity pain. What happens is that when you get a pain, there is a nociceptive peripheral input called somatomotor blocking effect. So there will be sudden blocking of certain muscle activity, which provoke adaptive. Okay, for example, a soccer player got a hit on his shin. You know, the shin injury, how much pain it is. It is high intensity pain. Whenever the pain it is, you can look into closely, you observe the player will be holding the breath for a long time. That means the diaphragm is contracting for a long time. When the diaphragm is contracting, it will go for a pathology, short-term ischemia, or sometimes they will undergo a neural blockage, okay, which may persist, which may open up suddenly. If it persists, there it starts diaphragm dysfunction. Okay, this is one of the neural explanation for, and any other structural, the connected structures, any of the somatic structures or visceral structures can cause diaphragmatic. This is one of the neurophysiological explanations. What happens? There is a neural blockage. Brain have a degree of freedom. Brain have other mechanisms to activate or continue with the breathing. Breathing cannot be stopped. So what happens? The adaptive mechanism will pump in. The adaptive mechanism are the neck muscles. Neck muscles, when you look at the morphologically, what happens is that they are not competent to do 24/7, 365 days respiratory function. What happens? There will be development of repetitive strain injury, trigger point formation, and giving trouble in your neck and shoulder and so on. Also, it affects, as the corset and lumbar stability and give you trouble in the back region also, the pelvic region. Okay. This all, I think we are all. So injuries, a violent fall, factors affecting the diaphragm function is violent fall or blunt injuries. We will be treating the peripheral somatic region, but we will not look into the diaphragm function. Trauma, twisting movements. Sometimes when you do some twisting movements, you will get diaphragm lock. Excessive cuffing, which is, we don't consider the patient have last week, he have an episode of cuffing, severe cuffing because of some allergy or some other reason. But after 2 to 3 weeks, patient comes with some neck pain or back pain. It is not necessary that we should take, while taking the history, the cuffing have any relation with the current problem. But there will be, because repeated cuffing will cause a diaphragm spasm and will cause a dysfunctional diaphragm and affect the posture or the cervical motor control. Ribcage strain, diaphragm spasm, or hypertonica. Hypertonica rectus abdominis. This happens with the bodybuilders with the six-pack position. You are isolatedly training one muscle. In human body, there is no isolated movement. There is always a synchronous group of muscle activity, and there is no muscle contraction. There is a group of muscle action. Okay, so when you try to isolate rectus abdominis and you training for it, what happens? They go for hypertonicity. The neural pool to the chain of muscles will only to the rectus abdominis will stronger. So any activity, instead of complete chain activation, what happens? The diaphragm or rectus abdominis alone will come into action. So this will affect the proper function of the diaphragm. Then cholecystitis, gallstones, diarrhea, severe vomiting, pregnancy, pleurisy, bronchitis, and pneumonia. This anything, even in tight dressings, tight outfits, even high-heeled shoes can de-align the pelvis and affect the corset and thereby affecting the diaphragm. So now I think you got the concept of the entire presentation. This is in order to assess the diaphragm, you should know what is the resting position of the diaphragm, convex position, dome shape of the diaphragm, laterally inverted J shape, vertical diameter of the thorax decreases. The central tendon, it's at the xiphisternal level, left dome of the at the lower border of fifth rib, and the right dome at the upper border of the fifth. This is a relaxed position of the diaphragm, but okay, just keep it in mind. So how do you assess the diaphragm? Diaphragm test. How do you assess the diaphragm? First of all, you have to observe the abdominal wall expansion, the movement of the chest during respiration, the scapular position, whether the scapula is in same position or scapula is moving, spine and head position, symmetry. All these components are very important. We should not only see the movement of the abdomen and neglect all other. No. It's not like that. When you are assessing the diaphragm, all these components have to be assessed thoroughly. If there is scapular movement, that means diaphragm dysfunction. There is spinal excessive movement or head movement. Sorry for that. There is this diaphragm dysfunction. There is asymmetry, diaphragm dysfunction. So you have to look into all these things while just observing. Then coming to the manual testing, you have to palpate, especially the lower intercostal separation, push and maintain the pressure during. There is two. I told two major functions, that is postural function and respiratory function. So when this postural and respiratory function, all other subsidiary functions will come into play. So the first point is lower costal separation is to look into the respiratory function, the complete usage of the diaphragm. And the second point, pushing and maintaining the pressure during respiration, dorsolateral position of the abdominal wall, is to look into the postural function of the diaphragm. Now, you have to give instruction to the patient. What instruction? First, you have to check the respiratory function of the diaphragm. Inhale against the finger in between the lower ribs and posterolateral abdomen. I said you ventral lateral and the dorsal aspect of the expansion should be assessed properly. So you have to assess the respiratory function. Then the second function is push against the finger while you inspire. Okay, that is the postural function. Now you have to give instruction to do dual function simultaneously. That is how functionality works. The other two assessment is separately assessing respiratory function and postural function. Now dual function of the breathe in and out, push against the finger, maintain the push against the activity, then inhale and exhale against the finger circumferentially. This is the proper testing of this. So what all things you have to know? Yeah, okay. So correct activation, there will be symmetrical posterolateral expansion of the abdomen, widening of the intercourse, balanced activity of abdominal wall, maintaining IAP during, that means postural function, upright spine and elongation. Incorrect breathing, there will be indrawing of the abdomen. So these are the 5 different, dysfunctions, what you can see. Diaphragmatic and abdominal breathing, there is abdominal breathing, there is no thoracic breathing. So with asymmetry, there is no symmetry. Right is more than left, left is more than right, or either the way, and limited motion on one side of the diaphragm. Okay, that means asymmetry. The second you can see is diaphragmatic and abdominal breathing still persists, but with anterior movement only, without lateral and posterior movement. That means the costal attachment is not giving proper movement. Okay, then comes the what happened? Oh, sorry. Yeah, the third one is diaphragmatic and abdominal movement is there with adequate antral and lateral movement without posterior. There is no posterior movement. That means it is mild diaphragm dysfunction. It is not. The fourth one is a little more severest form, chest or apical breathing pattern with excessive movement of the sternum, shoulder girdle towards the cranium, and minimal abdominal movement during inspiration. And the fourth one is the most severest form, that is a paradoxical breathing pattern, is when the abdomen draw inwards during inspiration and out during expiration. Okay, which is the severest form of the breathing pattern. Okay, so this is nothing but okay, this is also okay, fine. Yeah, so these are the poor muscle activation. You can see the excessive supraclavicular notch, the flaring out of the lower rib. There is drawing in of the the abdominal muscles, the pectoral hyperactivation, sternocleidomastoid hyperactivation. There is instead of craniocaudal movement, there will be opposite movement. There will be levator scapulae overactivation. There will be elevation of the scapula or shoulder girdle altogether. There will not be proper activation of the posterior part. There will be indrawing or the facial pulling of there is in the abdomen, etc. Yeah, there will be dimples on the posterior aspect of your paraspinal muscles. There will be flexion extension in the lumbar region while doing breathing, poor stabilization of the lumbar segment during expiration, anterior pelvic tilting, lumbosacral hyperlordosis, hyperactivation of paraspinal muscles, etc. So I think I almost finished the session. Now coming to the first question again. So we have to consider diaphragm as a muscle of concern while taking into consideration of human dysfunction, not on a specialty basis, because diaphragm is connected everywhere. It is not an isolated muscle, it is a system. Okay. And let us end up with one more quote from the Carl Levitt: "He who treats the site of pain is lost." I start with the Carl Levitt quotes and I finish with the Carl Levitt quote. I think I hope I give you a little bit of insight into our clinical practice. I hope you got some new things. I hope it helped you a lot. And I thank you for your patient listening for the last 1.5 hours. Thank you.
Yes, sir. There is a question in YouTube chat box. Can you view the chat box in Zoom?
I will read it out, madam. It was am I audible?
Oh.
Yes, yes, yes.
Yes,
Yeah.
yes, sir.
From Rini Khan, how to stimulate diaphragm transcutaneously in denervated condition?
Oh, transcutaneously, you have to, I don't know, this is in denervated condition, you have to place an electrode inside, which is beyond the current scope of medical science. I heard from one of my colleague who is practicing, he is a postdoc fellow in University of Florida. He is more into this diaphragm and research and all these things. From his explanation, what I understand is that science is still on a way to this. Actually, this ventilatory support mechanism is against the physiological mechanism, because actually the oxygen should be drawn inside with the contraction of the diaphragm. But what we are doing with ventilatory support is we are just pushing air into the lungs. There is no activation of this. So this question has a very significant, a very, 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 very nice question. I really appreciate for that person who asked this question. There is only method, I hope so, is placing an electrode somehow, but still it is on evolving. It's still evolving. There is no way, as far as I know.
I request our participants, those who are in YouTube, you can post your doubts in the comment section so that we can read it out here, or you can kindly join our Zoom meet. And the password and ID is posted in the YouTube comment section. And there are a lot of appreciations, sir. And one from Mumbai, Asfa, she is saying, wonderful, very nicely explained. Thank you.
The participants have joined in Zoom. If they have any question, then they can directly interact with the RP.
Yes, I received next question from Vijay Nambi. Is there any correlation between respiratory muscle weakness and balance or postural control in elderly population? Kindly explain about it. May I read it again?
No. I got the question. Yeah, obviously, but obviously there will be balance issues. As you see, trunk stability is required for pedal stability. If the trunk is not stable, or we have 4 appendages. All 4 appendages are not having good control, motor control. So diaphragm plays 2 roles, the postural role and the respiratory role. So if the diaphragm lost its function, it also most probably lost its postural control function. When the postural control function affects, it will affect the normal. There is 2 patterns of motor control: ideal motor control and non-ideal motor control. The body always have a mechanism, a compensatory mechanism, which is a non-ideal motor control, which is actually body meant to, or the brain keep this reserve mechanism to help you for time being. But if you use it for a long time, then it will affect the whole control system. Then it will go to tertiary ideal motor, non-ideal motor system, and slowly it will affect the structure. So before affecting the structure, there are a lot of processes. And throughout this process, it affects the proprioception, it affects the balance, it affects the control, so everything. So in order to gain more balance, we have to look into how effectively they are using their diaphragm, and how effectively the diaphragm is also in conjunction with the intrinsic myokinetic system to maintain the stability and the posture. When the joints come into the centrated position, there will be a free flow of proprioception. And when there is a free flow of proprioception, what happens? Ideal motor control will happen, and the balance will slowly, gradually improve. This is my explanation. I hope it answered the question.
Yes, sir. The next question is from Ayushi. Is it possible to stimulate phrenic nerve?
Yeah, it is possible, but transcutaneously, but on therapeutic basis, again, the question is still evolving, whether how effectively, like a cardiac implant, can we implant a phrenic nerve stimulator inside and help the patients with, and but actually we don't need, if the nerve is intact, if there is no nerve structural damage, organic damage in the nerve, there is no demyelinating disorder, there is no accidental injury to the cervical spine, actually there is no need of a stimulator. If there is a kind of nerve damage, then we have to not to stimulate the nerve, we have to stimulate the muscle, for which we need an intrinsic implant in situ to stimulate. That is still emerging only. Otherwise, by exercise, how to reactivate or stimulate the phrenic nerve is to bring the patient into the proper aligned position itself, the pelvic diaphragmatic position, and activation of the diaphragm using our conventional diaphragmatic breathing methods and all other methods. You can use yoga methods, you can use the stimulator pattern, you can use myofascial release of the diaphragm sometimes. Sometimes you can use rib mobilization. Sometimes one or two ribs are in inspiratory position because of the costovertebral joint arthritis or dysfunction, or according to Mulligan, it is sometimes it is in a positional fault. You can just mobilize it. Just mobilizing and repositioning the rib into the normal proprioception itself, the phrenic nerve will be active.
Yes. Yeah. So next question is from Ashraf Yasin. When to start regaining strength in the diaphragm in postpartum case, especially in C-section?
In C-section, breathing can be done in the beginning itself, but vigorous form of diaphragmatic breathing, I suggest only after 6 months. That means in different, simply sitting and breathing can be started initially itself, no problem, because unless otherwise it is not affecting your the site of surgery. You can start slowly activating with minimal exertion, but vigorous with the posture, activating with the posture should be activated only after 6 months.
Yes,
so the is deep, so that internal structures have to heal, get adhere each other. Until that, if you integrate the position, different positions into diaphragm activation, then it will create adversely, it will affect adversely on the cervical side.
Yes, sir. The next question is from Vijay Nambi. Is that respiratory muscle training improve or maintain diaphragm muscle postural function for elderly population?
Once more, sir.
Is that respiratory muscle training improve or maintain diaphragm muscle postural function for?
So which is the respiratory muscle?
He's saying the respiratory muscle training, whether the respiratory muscle training improve or maintain diaphragm muscle in postural function for elderly population.
No, of course, that is what we explained. Yeah. That is what we explained through the involvement of diaphragm on posture. And respiratory muscle training means you only have one option, diaphragm training. The others are subsidiary muscles. They are just helping muscles, or they are just in the pool. Yeah.
Yes, sir. The next question is from Sweta Desai. Sir, whenever we manipulate the spinal joints, would it help diaphragm as well?
Yeah, obviously, you look at the anatomical connection, they are connected to the lumbar region. So what happens is that sometimes if the vertebral facets are in positional fault, that means there is a proprioceptive problem. Whenever there is a proprioceptive problem, there is the feedback loop will be disrupted. So it affects the diaphragm. So sometimes when you do manipulation and when you relocate the joint into the right position, or sometimes when you create a movement in that longly malpositioned joint, then what happens is that when the proprioception become okay, the neural pool will be get activated, then will get activated.
Yes, the next question is from Dr. Akhil. Sir, I had treated a patient with muscular dystrophy, that is scapulohumeral muscular dystrophy, and he is having an excessive lordotic gait. While I tried to strengthen his abdominals, I noticed the same diaphragmatic movement upward as shown in the video. How can I correct that and train him? Normal breathing pattern. Is there any specific technique, sir?
There is no specific technique. You have to bring the pelvis and diaphragm into the parallel arrangement. Okay, one thing. Second thing, you can use facilitatory technique. You can use PNF techniques, or you can use any other facilitatory techniques as we have learned in our schools, in our cardiorespiratory normal quick stretches you can activate in, but you have to try to maintain the proper position of the pelvis and this thing. But still, if the child is responsive to your command, once you get that proper diaphragm exertion with your facilitatory postural correction, bringing the pelvis and diaphragm into proper, what happens is that this is muscular dystrophy. There is neuronal problem is not that much. So what happens is that when you proprioceptive, when you bring the spine into neutral position, and when you bring the diaphragm and pelvis into parallel facing position, suddenly gradually what happens is that the brain will get that the inhibition on the respiratory reflex mechanism will get slowly weaned off. So what happens is that even without your intervention, sometimes when you bring the posture into correction and when you bring the muscles into proper alignment, even without sometimes with your intervention, because the reflex, the inhibitory neural inhibition, the blocking has been removed. So what happens is that brain doesn't have any other mechanism or any other way rather than activating the inherent reflex, breathing reflex. Or so what happens is that sometimes with just a correction of the posture and bringing the pelvis and the diaphragm itself will reactivate the diaphragm. If still it is not functioning, and if this is the case of long time, the patient is long time in this mechanism, then sometimes you have to use thoracic mobilization and the quick stretch, reflex activation, PNF techniques, and this thing, pranayama, if possible, if the patient is obeying to the command.
Yes, sir. The next question is Hello, sir. Please wait. The next question is from Faiza. How do a tight diaphragm be released, and what does a strained diaphragm feel like? And we will take the next question from, who is that? Kindly raise your hand when you are asking questions in Zoom. Yes.
So shall I answer to the previous question, please?
Yes, sir. Yes, sir.
Yeah, there is facial, there is visceral manipulation techniques are there. There is facial mobilization techniques are there to mobilize this thing. How do you understand is that when you do abdominal palpation or diaphragmatic palpation, you will get a severe tenderness on diaphragm region. Or sometimes there is, which is called, I forget the name of that particular, it is called some point, Chaddock points. I think Chaddock points. If I'm wrong, please forgive me because I forget. It's in visceral manipulation, Chaddock points. Yeah. There are points for diaphragm. If you just palpate that, it will be severely tender. That means the diaphragm is under dysfunction or under pressure. I remember it is Chaddock points.
It's okay, sir. You can refer and post the message. I will forward it to the group. So
no
worries about it. So once again, you can cross-check the answer. So there are 3-4 questions more, and before we are going to that, I would like to Akhil to put your question.
Yes. So I have doubt regarding the muscular dystrophy, sir.
Yep.
Yes.
So can the doming of diaphragm exercise can be given, sir, for that case?
What is that?
Doming exercise for diaphragm, sir.
That I don't know what is doming exercise. What is that?
Sir, by placing our thumb in the diaphragm region and giving a quick stretch.
Yeah, obviously. Oh, I don't know the name. Sorry, I'm sorry. Yeah, obviously.
Okay, sir.
You can. That is your technique you are applying. Okay.
Yes, sir.
But that is again a neurophysiological stimulation method. You can do that. But you want more to, when you move from non-gravity position to gravity position, that means more functionally you have to bring the pelvis and the spine and the superior, the thoracic diaphragm and the pelvic diaphragm into alignment. That is more important when you come more functionally. But otherwise, just to facilitate, on the initial stage to facilitate and bring the awareness of the diaphragmatic movement, you can use that abdominal weight. You can apply a weight to the abdominal region and ask the patient to breathe in while expanding the abdomen and breathe out. That is actually more into, you feel non-functional. You don't have to consciously, but as a training in the initial stage, you can do that also. You can do theraband, try pulling and breathing in and expanding. All that your primary cardiorespiratory. What is that book called? Our exercise therapy book, no? That all exercise you can do. And then whatever you said, this doming, you quick stretches to the diaphragm. You can do.
Okay.
Thank you.
Okay, sir. But the problem is that since he's having the scapulohumeral dystrophy, he has severe winging of scapula and also the atrophy of his upper limb muscles, sir. So that's a challenging issue, sir.
No, scapula or winging and all this thing is not contributing to the complete mechanism of breathing. We are just talking about breathing. That is his pathology. That is still there because this scapular muscle during this 1 hour session, diaphragm dysfunction can affect the scapula, but scapular, the winging of the scapula doesn't have any direct relation with the diaphragm, I think so.
Yes, sir.
So that is different.
Okay.
And
Thank you, sir. I just put 2 questions together from Rimi Khan and Srivatsan Ramapriyan.
Excuse me, Chandramohan. Can we limit the question if you don't mind?
Yeah, yes. Only two more questions. That's all. I also want to finish it now.
Thank you.
So the question is the best position to re-educate or activate the diaphragm muscle maximally, supine or semi-reclining. Continuation, will cough assistive device help in stimulating diaphragm in paralysis?
Cough assistive devices.
Yes. And which position is best to?
Yeah. There is, like any other motor control. This is all about motor control. Okay. We are breathing is not a voluntary thing. It's a reflex. Okay. So what we are going to do, we are just reactivating the motor control system. So what mechanism, what posture you use for a stroke patient to reactivate? We start with the most stable position. You bring it to a little unstable position, to more unstable position, to more unstable position. Similarly, diaphragm rehabilitation also, okay. From the DNS point of view, I'll give you a clear answer that just to follow a child's milestone development. This is the answer.
Yes,
you start with the child milestone, the beginning milestone to the end milestone. Finish.
Yes, sir. One final question, and there are a few questions. I will send it through message to you. You can answer it later.
Yeah.
And we will post that in YouTube and also in our WhatsApp groups.
Okay.
So this is from Ayushi. What should be the first chest physiotherapy approach towards a pneumonia patient for effective drainage? So, question,
Oh my God. You are into cardiorespiratory?
Yeah, so
Into
you
that.
are talking about musculoskeletal, though it is not related directly to that. So, just wanted to have some idea whether the technique of deep breathing, huffing or coughing, percussion, vibration, which one is effective?
Once more, sir. Once more, I didn't get the
What should be the first chest physiotherapy approach towards a pneumonia patient for effective drainage?
effective drainage. Coughing, huffing.
Deep breathing, vibration or percussion?
Obviously, will be a huffing.
Okay, sir.
Yeah.
Thank you. Thank you so much. And I will be sending a few more questions in the chat. WhatsApp to you. You can answer. Those questions are also very wonderful. And there are a lot of praise in the chat box, in the comment box.
Yes.
And I request all our participants to give us a feedback. You can send messages to me. I can forward it to Shaheem sir.
Chandramohan, that is one of my requirement. Okay, that is one of my requests. I need a feedback because Chandramohan, what do you think? This is a conventional topic or a non-conventional topic?
So it's really, I was like, what you are going to talk about diaphragm? Be frank.
Yeah.
So, because for me, as a musculoskeletal physiotherapist, diaphragm means, yeah, I know that there are a lot of techniques which controls pain, but I never knew that this much is there. Okay, so even when we get hurt, if you take a deep breath and hold, we may for a few seconds we may not feel the pain also. So that's how we realize how breathing and diaphragmatic can help. So I never knew that we are having so much relationship with musculoskeletal. And the way you have presented with the video representations, it was really wonderful. It was a visual treat for us, not just listening to you like a radio, but it was a visual treat for us. Very nicely you have made this 1.5 hours worth listening to this program. And this is our first program for this year. And I'm so happy that we made our participants to have a visual treat. Hope everyone enjoyed learning a lot. And I receive messages also in WhatsApp that wonderful session it is. Thanks for sharing and all those things. And hopefully we will do another one more session after a while. And thank you so much for the wonderful session.
Thank you. Thank you.
Yeah. Thank you, Duna madam, for helping us.
Thank you, sir. Thank you, sir.
Thank you, Duna.
Thank you, Shaheem, sir.
Yeah, thank you, Duna. Thank you. Bye.
And I thank all the participants, those who are watching in our YouTube channel and those who are in Zoom. Thank you all once again. Bye-bye. Good night all.
Thank you. Bye.
Good night, sir.